Hello, everyone. I'm Mark Plaster, and you're listening to EP Talk, the place where ER docs can talk just about damn near anything. And I have my two guests today, Andrew Little and Andrew Phillips and Andy Little. I'll get the two Andys correct here. And thank you guys for joining me. And we're going to talk about something that's maybe a little touchy today. We're talking about training of advanced practice practitioners, PAs and NPs, and maybe the impact that's going to have or is having on emergency medicine residents training. So you guys are the educators. I'm gonna step back and throw the ball out there. Who wants to get it started?
Andrew, why don't you go for it? You brought this to the table, so.
Yeah. So as you mentioned, this is it is something very difficult to talk about for some reason. We can research guns, we can research religion, and somehow this conversation is really the third rail of emergency medicine. You may recall a couple of years ago there was the Yale study having PAs with the same education curriculum as interns, and the residents were left out as stakeholders, and there was a great consternation. It's such to the extent actually that the authors of that study had to write a letter to the editor that accompanied their original article. There was so much outcry when it was still in press before it was even published. Wow. So this is definitely a third rail. And it was difficult to find people to be a part of this study. Actually, this came to me because originally the people who had the idea for this were forced to not pursue it any further. And so this was not my original idea. People who had the idea,
not me, not me.
Right. And so yeah, with that, since somebody didn't want this study done, it had to be done. And I was proud of WestGem for not having any qualms. And Dr. Langdorf and I talked about it, Mark Langdorf, and we knew that this was going to be a polarizing issue. And I love being a part of this journal. The methods are good, the journal will publish. Yeah. And so with that, actually, you'll notice two of our authors are not emergency medicine, they're pediatricians. Anyway, what this looked at was the physician residents as stakeholders in education in the emergency department with the changing workforce. We've been talking a lot about the changing workforce in emergency medicine, but there hasn't been as much of a focus on the residents. And so the residents had not been addressed. And so we simply asked them, hey, what is the impact of the changing workforce on your education? Now, this is a survey, it's a national survey from AMRSA. And AMRSA has been pretty vocal about some of their concerns alongside the other specialty groups.
Define the acronym you just did. AAEM,
RSA, the Resident Student Association of the American Academy of Emergency Medicine.
Okay.
But the things they've been vocal about, a lot of it, these are joint letters that have been signed by CORD and EMRA and ACEP and such. So that was the group that we used as a national sample, and we simply asked them, like, what is the impact? This is their perspective. So it is a survey, but I think that's valuable to at least ask their perspective on things. That's what other people have been asking from the other stakeholders, what their perspective is. And we to make this as down the road as possible. So for example, we had some Likert style questions, we had some narrative style, and we asked on either side the positive things, what are the detracting things, and try to pull all this as even down the road as possible. And the findings were surprising and disappointing on multiple levels. About 66%, 2/3, said that having NPs and PAs in the emergency department was detracting or very detracting from their education. One of the things that really surprised my co-authors and I was on that dual side where we have a narrative response and just ask, hey, tell us the positive impacts, tell us some of the negative impacts. Again, 2/3, this is just free response, right? Now, the question asking what are the positive things, 2/3, their response was there is no positive thing. which is disappointing on so many levels that it was a free response. They could say what they wanted. Now, it's important to point out that there were some positive things that were mentioned. Other people had things to say. And when on the Likert scale question, it was off the top of my head, it was approximately 5 or 10% that you thought there were some fairly positive things that were offered. So there's a lot of variety. Clearly, some programs have this right. There's some positive things going on there. But I definitely did not foresee, when given just a middle of the road, hey, what are the positives, what are the negatives? I did not foresee that a vast majority could not come up with a single positive thing. And that's a problem for everybody.
Yeah. Yeah.
The other issue that came, well, there are a few more. The other startling factor in this, the postgraduate programs for NPs and PAs, there's just a growing trend. It allows departments to get a sense, because there's such variety in the education, particularly on the NP side. There are a lot of online programs and such, and so it's a growing trend for departments to have a postgraduate program for NPs and PAs, and allows them to select, it gives them the chance basically to road test individuals, if you will, and then hire the people who they think are a good fit for their department. Physician residents and programs that had these postgraduate programs lost 14 times the number of procedures. They're forfeited. So that's not total procedures lost. This is, you're a resident, you have a patient, and a procedure on your patient is explicitly taken from you and given to an NP or PA at a 1,400% or 14x. Now, the absolute numbers were not terribly large. It was 0.5 median there, 0.5 versus 7. We don't have a denominator, so maybe 7 forfeited procedures out of 30 or 40 or whatever it is. This is total procedures, right? And we have it in the supplemental material all the procedures that we're talking about. On Twitter, some of the conversations were like, well, this is just cherry picking or whatever. And we knew this was going to happen, right? So my co-authors and I, it's over 30 pages of metadata with all the precise, everything people wrote in the narrative response, word for word, verbatim, is on there. People can see how we coded it.
Give me an example
along
of
with all their answers.
Give me an example of the procedures that you're talking about.
Great question. We pulled this from the ACGME procedures for emergency medicine, all the requirements. Okay. So chest tubes, central lines, intubations. This was drawn from our requirements in emergency medicine.
Okay. So
were you able to tease out, Andrew, which ones were being taken, or was it just procedures in general?
We just asked them procedures in general. If you kind of stratify, clearly people did more central lines than they did chest tubes. Some of the narrative responses were suggestive of this is my draw on it. My kind of guess, my take on this from the narrative responses was the forfeited procedures tended to be the less common ones, like chest tubes were specifically brought up. And the circumstance of that was the trauma team wanted their NP or PA to do the chest tube. And so the ED resident did not get that. That was brought up, I think, 2 times, 1 or 2 times at least, trying to draw from those narratives. But no, it did not drill down to, I was not expecting that many. I was not prepared for that number. I'll be honest. It was surprising to me.
I have to say that if you were running an emergency department, and the trauma team came down and booted out your residents to train their PAs, not only would it be a training issue, it would be, I hate to say it like this, but an image, and you wouldn't get people, you wouldn't get residents to come into that program if they knew that was happening. To be treated less than than a, I hate to say it like this, to be treated less than a PA, okay?
Yeah.
To stand behind a PA to get something done, to train. That's...
Well, it didn't all, one of the things that we looked at was not just the emergency department, but it happened off service as well. It actually happened with more frequency off service than on when you're down in ED. Because this is a major part of our education as well, is off service.
Yeah, I was going to say, it's as I was reading this paper, it was interesting to highlight on the fact that we don't have an APP training program in our department that runs tandem with our residency, but most of our off-service rotations utilize APPs for, again, they utilize APPs for a resident role. Let's just be honest. What they're doing is they're hiring APPs because they don't have fellows, they don't have enough residents to have their service packed every time, and some of those are at PICU, medical ICU, trauma, where NPs, well, the feedback we get repeatedly is that, well, we're pushed out of the way for the NP to get procedures. And then we go back to the preceptor and we say, hey, here's some feedback we're getting from our learners. they're like, well, our NPs have to maintain competency, or we need to get them trained up. And so they're going to be taking procedures from your residents. And we've moved our residents out of units and off services, specifically targeting services that don't utilize APPs, knowing that this is a constant problem. And it's a growing problem because APPs are cheaper than getting a resident on certain services, because they can be there all the time. And so it's a growing problem. It's not just in the emergency department. So no, I think this study is one of those, we asked the question nobody wanted to ask, Andrew. Like, nobody wants to ask this question because they know that APPs will be doing, like, they know this is going to happen. But it's better it's a question nobody wants to ask because we know the question, we know the answer, and the answer doesn't put anybody in a good light, because now you're having places of education utilizing APPs over residents to perform care that was traditionally done by a resident, but now we're asking residents to become competent at procedures and patient care in settings where there are other people who are taking their experiences.
And the reason why this is this is not just a pissing contest among the trainees. We're training emergency physicians to go out, and they're not going to be in places where there are APPs knocking them out of the way to do these procedures. You're going to be doing it. I spent 35 years at single coverage. Okay, there wasn't anybody helping me, nobody. And so if I had not been trained properly to do that, if I see one, do one, the folks that I was taking care of would be in a heck of a lot of trouble.
I'm glad you brought that up, because that was my take as well, with the difficulty finding people who are willing to do. I mean, we were turned down. People I've done studies with previously. We have a good, research relationship, strictly because of the topic. They feared retaliation at their institution. So, to your point, we had a sense of what we were going to find anecdotally. I was surprised with the extent of the problem. But I think you're right. Because why else because there are studies looking at the perspective from the NPs and PAs, looking at there was one in the ICU actually that asked the program directors or the fellowship directors, does this work out fine? Are the residents or the fellows okay? And the fellowship director's like, oh yeah, this is great. And no one asked the fellows. I mean, it's a glaring loss it's a they're glaringly ignoring. It's not very eloquently phrased, but you know,
it's an oversight, right? It's an oversight. Yeah.
It's a huge stakeholder to just ignore. And the second part, well, I guess the second part of this, because I've done multiple second parts here. The other thing that I want to bring up is the most concerning part for me out of all this, despite these numbers, 14x, whatever, was that we also asked, do you feel like you can bring up these issues at your local leadership and nationally with the ACGME survey? There's an open-ended thing in the ACGME, and it happens that this question has come up recently as part of the revamp of the ACGME survey. And the vast majority of residents said no, they did not feel confident they could bring this up with local leadership without retaliation. And no, they did not think the ACGME was able to satisfactorily address any concerns. So now we have a problem identified and no confidence in the institutions that are supposed to be available to remedy it. So we are behind the 8 ball in terms of even beginning to address the issue.
Well, why? Okay, wait a second. These institutions are their purpose is to train residents optimally, okay, and they're not going to back the residents.
For the resident perspective is no. They fear retaliation. Majority, it was something like 2/3, 64%, 66, something like that. 2/3 of residents feared retaliation. Well, they said they were not confident, or greatly not confident, that they could not raise these concerns without retaliation on their local leadership, which doesn't surprise me with conversations I've had with people. If we can't even get faculty to take on this topic as a research study, residents are absolutely going to fear retaliation for raising concerns. Who does not surprise me.
That, just to be more specific, who is it that they fear? The residency director, the hospital administration,
I don't know.
Yeah.
We did. So this is very much.
What's your feeling? What's your feeling of that?
Center.
Yeah. What's your feeling of that? Andy, what?
I don't. Yeah.
So, I mean, I think to me, it's probably a global thing. It's when I talked about it at our shop, we've had that feedback, multiple rotations, multiple times, and we're running out of units to put our residents in, to where I imagine there will be a day that a resident can come and complain to me and say, hey, on this rotation, I don't get anything because the NP or the PA gets all the procedures. They get all the sick patients. We're not trusted to take care of these patients. And I'm not going to have a unit to put them in that doesn't have that kind of model. And even as an educator, my hands will be tied because of the financial benefits of having an advanced practice provider practicing in a clinical setting. And so I imagine there are places where maybe they've even brought this up, and the faculty, PD, DIO say, well, this is the way we run our hospital. Sorry. To where, and maybe it's not that the retaliation is there, but maybe if they think if they're going to make a stink about it, then that's going to cause a huge problem. And so I think it's probably multifaceted. And again, it's because hospitals and institutions have a large financial benefit of having APPs practice in specific clinical settings. Specifically, frankly, it's critical care units, because those are places where we have a shortage of physicians. Bigger hospitals can't just start fellowships out of thin air. And so they'll hire a slew of APPs to take care of their patients, which will push a learner out from the bedside. Because even the APPs, as they get farther along, maybe they'll let an APP supervise a resident. That comes up pretty regularly for us, on top of issues of APPs taking patients, is we'll have residents working under APPs without our knowledge. And that's considered an appropriate educational model, which again, there are APPs who have been doing their jobs for a long time the residents can learn from, but that's probably the exception to the rule. But I imagine if you were to do that survey, you'd be seeing even more of that, to where on specific services, residents are being supervised by APPs.
There's a lot more to unpack here. And one of the things I definitely want people to, if they've gotten hopefully this far in the podcast, I'm making no statement that this is some kind of definitive finding, right? Yeah. The better way to look at the procedures is to look at all the procedure logs, to be sure. Now, we asked a question about forfeiting because that's specific. Procedure logs are not going to reflect a procedure being taken specifically from a resident. And we were very careful. I actually wrote an article for West Gem about what are the indications for using a survey methodology, because it drives me nuts when people do the wrong thing, do the wrong method and use survey appropriately. So specifically, the forfeiture was what we were looking for on this. But this is just the tip of the iceberg, and there are empiric studies that need to be done. More, broader national samples. I think, looking at all of RSA, which has approximately half the programs in it, is a pretty good sense of things. But there's a lot to unpack here, and we just asked the initial questions. I would like to know, of the procedures forfeited, what were they? I need to know a denominator. If you lost one central line, but you did 40, okay. The thing to point out as well is it did go both ways. It swung heavily towards the residents losing procedures to the NPs and PAs, but some people also mentioned, for example, as Andy brings up, that their NPs and PAs have been doing this for a long time. Several people mentioned in the narrative response that the NPs and PAs would give them procedures. They've done a bunch of central lines, and they don't need anymore. So they see it as a chance to teach the residents and the NPs, to your point, Andy, that can happen. The question is how often. And one of the things I think to tease out of this, and it would be very difficult, but the why were procedures forfeited. And the answers to that were given a little bit in the narrative responses, but it was quite varied, and it ranged from unit culture to, very commonly, the NPs or PAs needed it because they had a limited amount of time. They were onboarding, they had a short postgraduate program, which then begs the question is, if they only have a year, the NPs and PAs in these postgraduate programs, or say 6 months or 4 months or whatever it is, onboarding, and the ICU, I'm living and breathing that, right? I know exactly what you're talking about, Andy, with that help. Then are we getting into a model of giving priority to people who have a shorter training period, and then making the physicians do their 3-4 year residencies to wind up with a similar number of procedures?
Mhm.
So then the fast road to a similar number of procedures is the MP or PA, whereas we stick around and our rate of procedures is less. You know what I mean?
Yeah.
Is that
Yeah.
the direction that we're headed, and is that the direction we want to be heading? To be clear, that's not in this study. That was not established with these data. But from some of the narrative responses, that's certainly happening in some places.
Well, I don't think you have to take too many steps down the road to say, all right, so in the current state, how much does it cost to train a resident? So in emergency medicine, it's at least 3 years. So that's, $500,000. How much does it cost to train an APP? If it's 6 months of their annual salary, that's 100K. So that's 50K that a hospital will put up to train an APP. And eventually somebody's going to figure the money out. Now, granted, residencies are funded by federal funding, but eventually I imagine there'll be a discussion of, is it better for us to have a 3-year EM residency where every year we get new interns, or is it better for us to have a 6-month APP training program where we can train them to do, I'm not going to say everything that a resident does, but let's say they can do 85% of what a resident can do. We won't let them intubate. We won't let them put in, pacers. We won't, they'll pick a handful of procedures they're not allowed to do. They're not allowed to run codes. They're allowed to do, but somebody's going to do that math. And unfortunately, the math is not in the EM resident's favor in this regard. And so, that's not a hard leap for me to make. That's literally just somebody figuring out the funding of it all, and they'll realize it's cheaper to have APPs.
I think that from a guy who's at the end of my emergency medicine career, we worked too hard to get to this point.
Yeah.
Okay. Where emergency medicine specialists are recognized and appreciated and demanded. And I think that if we are not careful, we will give this specialty away in short order. And I think that the leadership of ACEP and AEM and all that, they need to be aware of this. And they need to be stepping up big time. And the public needs to be aware of this. Is this who you want treating you? I mean, I have family members who go into the units. They never see a doctor. Okay. Mm-hmm. They never see a doctor. And people they have APPs making strategic decisions for their health care that I'm not sure they're qualified to make.
Yeah.
Your point about the specialties I thought was interesting. Oh, sorry.
It's not just, I guess what I'm trying to say is, I think the procedure aspect is just the physical part you're seeing. Mm-hmm. And it has to reflect in the thinking part as well, which is probably even more important, but it's the indicator. If you're not getting the procedures, you're not getting the teaching as well.
So your point about the thinking part, I think, is a good segue to another part that surprised me. We looked at associations with the postgraduate programs for NPs and PAs, right? We saw the association with increased forfeited procedures, but having that program was not associated with a worse sense, a greater detraction of education. Okay. So which surprised me, because if you're losing procedures, I would have imagined that. So the more procedures you forfeited was associated with a worse score on, they're more detracting my education. That made sense to me. But having a postgraduate program for ICPs and PAs was not associated with worse detraction scores in and of themselves.
Yeah.
So there's something on the education side, the brain side of this. It's not just procedures.
Well, I wonder if that's because if you look at EM programs that have APP programs, because of the Yale paper that came out, I truly believe that EM programs changed how they train APPs to where they're no longer training APPs to replace EM docs. They're training them to fulfill a role within the department, i.e. they're not putting in chest tubes, they're not putting in central lines. But I wonder if the procedures are more tied to off-service rotations, i.e. MICU, PICU, ortho, and general surgery. So I think that's where the next study is teasing out, okay, so here's what the study showed in terms of procedures. Was this actual EM APPs that were doing this, or was it off-service APPs? Because I think that's where you'll find some interesting data points where maybe within EM, we figured it out how to train them coincide to where, because we're not training APPs in the emergency department to do critical care procedures, but to fulfill a role within the ED, is that different versus them being off-service, where that's not the case? So,
well, the procedures that we looked at were specifically in the ED.
Okay, so that actually
Now,
wasn't okay. All right.
yeah. So now you could be saying, is it that service coming down? We did not tease out. Is it
Yeah.
like the trauma? I'm not trying to knock on trauma, but that's
No,
a
no, yeah,
common
yeah.
occurrence, right?
Yeah.
Is it the NPRPA from the trauma team coming down as a consultant taking the procedure, or is it the with our own community, so to speak, in the emergency department?
Yeah.
And we're focused on residents on this. I think it's equally important to mention. I didn't, we did not focus on the PAs or NPs and asking their perspective on this because we were focused on the physician residents who had not previously been asked. Some of these data have been established already in smaller studies for the NPs and PAs, but of course their education is important as well for whatever role they're going to fulfill. And this is the issue with not being able to ask the question. This has to work. So we have to be able to ask the question. We have to be able to talk about this and figure out how everyone gets the education they need. Our patients depend on that. We can't be taking procedures from NPs and PAs who need them. We can't be taking procedures from physicians who need them. It was the forfeiture that caught me. I think we can expect, just like if you have off-service residents, the patients are split, right? And you do your procedures on your patients and such. But I think everyone's got to walk out of this somehow sufficiently educated.
There's enough. You guys have been in practice as well. You know about skill degradation. Mm-hmm. And you can't have done just a handful of things in residency before you come out, because that may be the peak of your skill level. If you're in a community setting where you are not intubating patients as rapidly as you did in a level 3 center, if you're in a community center, and most of us we're trained in academic centers to go into community settings. We may not want to, but we really need to. And if you are going to go into a community setting where you're not really adequately trained to do that by yourself, we've done the public a disservice. And because the buck stops with you. Okay. And so we're running out of time, guys. This is incredibly important. I hope that our listeners grasp that. First off, Andrew Little did a brave thing, okay, by opening a can of worms that we've known was there for a long time, and that we really need to address openly, honestly. What's best for the specialty, what's more importantly, what's best for our patients, and not just the ones that are in tertiary care settings where training is occurring, but all the other places. Okay. And we need to make sure that training is occurring optimally for everybody involved. So I just want to, we've got a lot here. We can talk about this some more, but I just want to thank you all for coming in and joining us, and we'll pick it up at a later time.
All right. Thanks, Mark.
Thanks, everybody.
Thanks for having me.